those abstracts and presentations for you. So this year, DDW did something very interesting and I think very helpful, that they had FDA town hall presentations for drugs that were approved between DDW 2018 and DDW 2019, and two of those drugs were Prucalopride and Tegaserod. And not just about the efficacy of the drug, but mostly about the safety profile of the drug to let us know what was the reasoning behind the box warnings and also the contraindications that are in the product insert. So I'm going to walk you through those talks that was presented by Dr. Tomeno from FDA. So we all remember Tegaserod or Zelnorm that was introduced in 2002. It's a 5-HT4 agonist, but it does have affinity to other 5-HT receptors. It was pulled in 2007, and that's because of the cardiac side effects that it had. And there was a painful process after 2007 that you would be able to get it for the patient, but not many of us went through that because there was a lot of paperwork. But now it has been reintroduced to the market starting April 2019. Still not yet available, but now approved. So now the approval is only in women less than 65 years of age and IBS-C, not CIC. So the dosing is the same as the past, 6 milligram BID, 30 minutes before meals. So contraindications have changed, and this is different from the product insert in 2002. So what are the contraindications? The contraindications are essentially CVA. If patient has history of CVA, whether it's MI or TIA, it's contraindicated. You can't use it. If patient has history of ischemic bowel, then again, this drug is contraindicated. Also, if patient has severe renal impairment, defined as GFR of less than 15, or severe hepatic impairment, defined as Child-Pugh B or C, again, this drug is contraindicated. Another thing that is new is if patient has symptomatic gallbladder disease or sphincter of OD dysfunction, then you can't use this drug because there is some post-marketing data suggesting that this drug can cause sphincter of OD dysfunction. So that is also a contraindication. So a mouthful of contraindications that you need to remember, and some of them are not as intuitive as you can think of, like symptomatic gallbladder disease or sphincter of OD dysfunction. So common side effects. Headache 14%, and now we know that probably headache is a class effect from all 5-HT4 agonists. The headache is a tension-like headache. It's almost always immediately starts after starting the drug. It's transient. If you decrease the dose, it decreases in intensity. But sometimes the severity of headache is so much that we have to stop the drug. Just like any other pro-motility drug, abdominal pain and diarrhea are also seen with these drugs, and it's a cramp-like abdominal pain. Diarrhea is also usually a transient. It's not similar to secretagogues, that if you get diarrhea with it, it's very hard to control it, and sometimes we have to stop it. Generally, the diarrhea associated with 5-HT4 agonist, it's transient and eventually stops. So this is a new box warning on the drug, suicidal ideation and suicidal behavioral changes. And this is based on the post-marketing data that showed up, essentially with 8 out of 10,000 subjects in the Tegaserod group attempting suicide versus 1 in 5,400 subjects on placebo. So it's a small but significant risk. So because of that, there is a box warning on Tegaserod, and that's the word-by-word recommendation by FDA on the second point that you see over there. So you have to monitor all patients for worsening of depression and emergence of a suicidal ideation, but it does not mention how frequent and how long. Also, they mention counsel family members and caregivers in regards to development of these symptoms, which is a bit tough for us because we're not pediatricians, so when we usually see patients that are coming to our clinics alone. So how do we counsel family members? That's a bit tricky. So what happened to the cardiovascular side effects that led to approving this drug in 2007 anyways? So FDA performed 2 external adjudications. On the first adjudication, as you can see, it showed that there were 7 cases in Zellner group that patient had cardiovascular events, as opposed to 0 in the placebo group. And the second adjudication, again, showed that there's a difference in them. It's small, but a significant difference. If you just limit the patients to females less than 65 years of age, the risk decreases significantly. And that is the reason why this drug is approved for women less than 65 years of age, not because the drug is not efficacious for women above 65. It's because the FDA considered age more than 65 a cardiovascular risk, so they limited the drug to patients less than 65 years of age. So at the end, FDA could not conclude that cardiovascular events are not associated with Tegaserod, so there is still a box warning for cardiovascular events, even in women less than 65 years of age. So they had also a town hall presentation on Prucalopride, which is another 5-HT4 agonist. The difference between this and Tegaserod is that it has a higher affinity to 5-HT4, which is more abundant in the gut. And so hence the idea was that it has less side effects. So it was approved again in December 2018, and it is available in the market. I'm not going to go through the efficacy data, but generally number needed to treat for this drug is roughly around 6 or 7, depending on which RCT and what definition of chronic idiopathic constipation that you can see. Also, one important note is that in terms of indication, Prucalopride is approved in chronic idiopathic constipation. Tegaserod is approved in IBS constipation. The dosing is 2 milligram daily with or without food, doesn't matter. And also 1 milligram daily if the GFR is less than 30. And that is why the drug is available in 2 dosing, 1 milligram and 2 milligram tablets. Contraindications are relatively straightforward, so intestinal perforation, obstruction, and also severe inflammatory disease such as Crohn's disease. So side effects, as expected, headache is up there, 19% versus 9% in the placebo group. I described the pattern of headache with Tegaserod, the same story here, and also abdominal cramps. That can happen with this drug. And also decreasing the dose usually helps with both headache and abdominal cramps that you can get with these with patients. So this is an interesting story. If suicidal ideation would not have lit up with Tegaserod, this wouldn't have even looked at in Prucalopride. But obviously FDA, as this looked at the suicidal ideation in Prucalopride because it's a 5-HT4 agonist. And what they found was that there was 1 case out of 1,250 patients translating in the rate of 0.08% versus 1 suicidal attempt in the placebo group out of 1,200. So they could not rule out whether suicidal ideation can be associated with Prucalopride, and because of this, the drug does have a box warning for suicidal ideation, and you need to follow up the patients to make sure that they do not develop suicidal ideation or depression. But again, no guidelines on how long and how frequent you have to do that follow-up. So FDA determined that there is no increased risk of cardiovascular events with Prucalopride, and that was based on the randomized controlled trial data and also the post-marketing data coming from Europe that compared Prucalopride with PEG, and they did not show any increased risk of cardiovascular events. So there is no box warning for cardiovascular events for Prucalopride at this point. So summary of box warning, for Tegaserod, cardiovascular events, suicidal ideation, ischemic colitis, and also if you're volume depleted, obviously you shouldn't use any type of laxatives anyways. And for Prucalopride is suicidal ideation. Another study that I want to walk you through it is a study that was done in small bowel microbiome of patient on and off of PPI. Over the last few years, you've seen multiple studies coming out showing that multiple side effects may be linked with PPIs, and that has caused quite a bit of a headache for us in the clinic, trying to explain the side effects of the PPI to the patients. But also in the last few months, we have had better studies coming out showing that some of these associations are just associations, that there is no, at least, definite causal relationship. And these complications are CKD, dementia, osteoporosis, and one of the common questions that patients ask are the fact that whether PPIs cause dysbiosis or small intestinal bacterial overgrowth, and they're worried about that. So this study was trying to assess that whether PPI can cause dysbiosis and small intestinal bacterial overgrowth, both based on culture or sequencing. So this was a part of the REIMAGINE study, which is the largest program ongoing in the world, trying to map the small intestinal microbiome. Assessment of small intestinal microbiome is a bit tricky as compared to stool, because stool is easily available and you can check it and do deep sequencing on it. But small bowel microbiome, when you do the endoscopy, obviously you're dragging all the oral and upper respiratory tract microbiome with you all the way to the duodenum, and now you're pushing a catheter inside the suction channel that is already dirty with the other types of microbiome. So it's a mucky picture. But this study is using a double lumen protected catheter that goes through the suction channel and then goes beyond the scope and suctions the small bowel contents to avoid the microbiome contamination from the upper respiratory tract. So that is why we believe that this is a more conclusive data in regards to small bowel microbiome. So on this side, you can see patients on no PPI, 172, versus patients on PPI. So for a microbiome study, these are very large numbers. And if you look at it, and this is called sunburst diagram, and it goes from phyla all the way to the genome of the bacteria that you find. But if you look at only the phylum here as compared to patients on no PPI versus the patients on PPI, they're almost identical. So at least we know that PPIs don't nuke the small bowel microbiome. The microbiome remains almost identical at the phylum level. From the diversity, which is the lack of diversity, you can, in layman terms, call it dysbiosis. You can see that no matter what index that you use, the diversity of small bowel microbiome is exactly the same for patients on PPI and not on PPI. In terms of beta diversity, you will agree with me that essentially clusters of PPI and no PPI patients are overlapping. So overall, not much of a big change in small bowel microbiome, which probably is the most important microbiome in our body in terms of pathophysiology. There's not much of a change. How about SIBO? In terms of cultures, rate of SIBO defined as more than 10 to the 3 CFU per ml as per North American consensus is 27% versus 24%. So essentially no change. In fact, actually it was slightly lower, but this was not statistically different. as defined by the criteria based on sequencing. Again, there was no difference. And if you define SIBO based on 10 to the 5, again, it was 12.5% versus 13.8%. Again, PPI do not increase the risk of small intestinal bacterial growth based on the largest study done in this field, so which is reassuring for patients when they have these questions. So why is this happening? Why PPIs are not affecting the small bowel microbiome dramatically? One explanation can be the fact that small bowel pH does not change much with PPIs. Within 5 centimeters of chyme entering the small bowel, pancreas neutralizes the pH using its bicarbonate to a point that it reaches about 5.8 to 5.9. And this has been shown in multiple studies. So maybe that is the factor that is contributing to the fact that PPIs, although they change the pH of the stomach, they do not change the pH of the small bowel, so the microbiome in the small bowel is not changing. And also the fact that the main component that keeps the dysbiosis away in the small bowel is the motility of the small bowel. So if you have a normal underlying small bowel motility, you're not going to get dysbiosis with PPI. That's the summary of it that I usually tell the patients as well. So this is our group at Cedars that are involved with the REIMAGINE study. And after this, I'm going to hand it to Eric.